Rural hospitals are under constant pressure, struggling with limited resources and geographic isolation. But a bigger crisis looms: a projected shortage of 3,500 specialist physicians, including radiologists, by 2034. For rural communities, this means canceled scans and patients traveling hours for critical care. What if this could be fixed by a quiet but powerful change in CMS regulations? We'll now break down new CMS rules for virtual supervision and show how they improve rural hospital operations and care. First, CMS extended the allowance for virtual direct supervision of contrast imaging through the end of 2025. But the real news is this: CMS finalized plans to make virtual direct supervision permanent starting in 2026. Virtual direct supervision allows a qualified radiologist to oversee a procedure from anywhere, using secure, real-time audio and video. Your on-site technologist is with the patient. On screen, the supervising radiologist is immediately present, ready to guide and intervene. The policy is clear, but how does this solve the massive staffing and access problems we started with? The answer is in how this change re-engineers resource allocation. It decouples expert oversight from physical location. This is powerful because one off-site radiologist can provide direct supervision to multiple rural facilities at once. Their expertise becomes a network resource. This directly answers our question. You no longer need a radiologist on-site at every location. It multiplies the impact of the specialists you can access. Benefit 1. Scheduling becomes radically simpler. You can extend operating hours without the logistical nightmare of coordinating an on-site physician. Benefit 2. Patient-facing delays are removed. Imaging can proceed immediately without waiting for a radiologist to become available on-site. Benefit 3. Coverage expands across time zones. A network can use radiologists on the East Coast to cover evening hours on the West Coast. These operational improvements are not just theoretical. They translate into hard, measurable gains. Let's look at the data. The first staggering statistic is speed. Studies show virtual supervision can deliver 30% faster response times than traditional on-site oversight. Why so much faster? A remote radiologist is instantly present. There is no time lost walking from a reading room or another part of the hospital. This 30% improvement means higher patient throughput and reduced wait times. It frees up the entire on-site team to focus on direct patient care. The second major impact is financial. Analyses show this model can cut operational costs by up to 30% from better staff allocation and less idle time. Remember the looming radiologist shortage? Models that are 30% faster and 30% cheaper are a direct countermeasure to that threat. But efficiency and cost savings are only part of the story. What does this mean for the most important person in the room? The patient? The most profound impact is keeping patients in their local community. It removes the immense burden of travel, time off work, and stress. This is not just convenience. It is access to a higher level of care. Rural hospitals can offer services previously only found in urban centers. This is the evolution of teleradiology, from just reading images remotely to active, real-time participation in the diagnostic process. So we've established 3 pillars of value: operational efficiency, major financial savings, and transformative patient access. How do they combine? The new model is one of resource multiplication. We are not just managing scarcity. We are amplifying our existing expert resources by taking the permanent CMS rule change and applying it through technology that delivers 30% faster response times. Rural hospitals change their equation. This combination directly attacks the physician shortage. It makes every radiologist more effective, covering more patients and driving cost savings. Ultimately, virtual supervision turns a rural hospital's greatest weakness, geographic isolation, into an operational strength, creating a resilient network. The conclusion is clear. The new CMS rules for virtual supervision are not a minor update. They represent a viable, powerful, and permanent lifeline for rural hospitals. This is the future of rural care: empowered local teams and equitable access to diagnostics. A future where your zip code does not determine your quality of care. For hospital administrators, radiology managers, and policymakers, the time to act is now. Begin implementing these models for the 2026 rule change. This innovation is not just about technology. It is about fulfilling the promise of healthcare, to provide the best possible care to every patient, everywhere.